With François Dabis. François.
Good morning. I'm François Dabis. I'm Professor of Public Health at the University of Bordeaux in France and the head of INSERM research group working on HIV and cancer and global health in Africa.
So this session is on science in prevention to end the HIV pandemic, and we have distinguished speakers on different topics concerning prevention. And François, first you have to present the first speaker.
Thank you. We will have as a first speaker Virginie Supervi. Virginie is a researcher from INSERM Unit 943 in Paris, and she will review with us the issue of improving prevention and early diagnosis. Generally speaking, and probably in France in particular, I hope.
Okay. Good morning, everybody. So first, I would like to thank the organizer for inviting me today to talk a very important issue, which is how to improve prevention and early diagnosis. So I have no conflict of interest. So as you all know, HIV infection generally goes unnoticed for several years. So this means that when a person is newly diagnosed with HIV, in general, they were likely infected for many years without knowing it. This poses two big issues in terms of controlling the epidemic. First, it is very challenging to track the current state of the epidemic. Because surveillance system can only bring information on diagnosed individual, and there is a time lag between infection and diagnosis, which can be very long. For example, 10 years for people who are first diagnosed with AIDS. So this is very important to have some understanding of the current HIV transmission dynamic to control the epidemic. The second issue is that there are many HIV-infected individuals who are unaware of their HIV infection. And undiagnosed individuals have a high risk of transmitting HIV because they cannot make informed decisions about their sexual behavior, and they cannot benefit from treatment that could greatly reduce their risk of onward transmission. So therefore, undiagnosed individuals account for most new HIV transmission. So what will it take to end the epidemic? First, we need to track the current state of the epidemic. Then we need to reduce the time lag between infection and diagnosis, and we need HIV prevention method in order to prevent the acquisition and the transmission of HIV. So in the following, I'm going to talk about these three main issues. So first issue, tracking the current state of the epidemic. So to track the epidemic, we must have some information on new HIV infection, which is HIV incidence. And ideally, we would like to know where the next 1,000 HIV infection will occur. So how do we track the epidemic today? So today we use data collected by surveillance systems together with mathematical modeling to estimate national HIV incidence. And HIV surveillance in high-income countries rely mainly on the reporting of new HIV diagnoses, while in low and middle-income countries, it relies on seroprevalence data obtained from antenatal clinics and demographic and health surveys. However, the current surveillance system have some limitation. In high-income countries, data on newly diagnosed HIV cases suffer from underreporting and reporting delay. For instance, in France, underreporting varied between 30% and 40% over the last year. So underreporting can be accounted for in the estimation process of HIV incidence. However, it requires making an extra assumption. And because of reporting delay, we cannot get an HIV incidence estimate in the very recent past. In low and middle income countries, HIV surveillance initially relied on prevalence data collected in antenatal clinics. However, these data are not representative of the general population. So when HIV surveillance was strengthened through the conduction of population-based HIV testing survey, this had for consequences a major revision of a country's HIV estimates. For example, HIV incidence estimates decreased by 39% in sub-Saharan Africa between 2006 and 2007. And today, population-based HIV testing surveys are designed to be representative of the general population. However, they are also vulnerable to selection bias, because between 5 to 45% of the persons that are contacted for the survey do not consent to HIV testing. So today's surveillance system have some limitations that can affect the accuracy of HIV incidence estimates, and thus our understanding of the epidemic. So these systems need to be strengthened. In high-income countries, it will be important to reduce underreporting and move towards real-time reporting on newly diagnosed HIV cases, so we can determine real-time changes in HIV incidence. In low and middle-income countries, there is a need for additional methods to estimate HIV incidence, which rely on other sources of data than those currently used. There are some pretty good data on the number of persons who initiated antiretroviral treatment over time. And we recently proposed a new method to estimate HIV incidence using this data. In all countries, it is important to become more refined and move from national to regional assessment of the HIV incidence, because there is some substantial geographical heterogeneity in HIV transmission. And furthermore, it will be essential to describe the concentrated sub-epidemics within generalized epidemic settings. Although there is some data today showing that the prevalence of HIV is high among subpopulations, such as MSM and sex worker, there is no HIV incidence estimate for this subpopulation in generalized epidemic settings. HIV epidemics are highly dynamic, so we really need accurate and real-time estimates of HIV incidence to be able to implement effective targeted HIV prevention programs, evaluate them, and possibly reorient them. Okay. Now let's discuss the second point, early diagnosis. So to improve early diagnosis, obviously we will need to implement an intervention to increase HIV testing uptake. But before that, we need to know two things. First, how early or late are HIV infections diagnosed today? Second, we need to characterize the hidden epidemic. Who and how many persons are living with undiagnosed HIV? So these two things are essential to implement and assess the impact of HIV testing intervention. So to assess the timeliness of HIV diagnosis, we can use data on CD4 count at care entry. So these data are in general available in high-income countries. On this figure, you can see the black line shows the evolution of the mean CD4 count at care entry between 1992 and 2011 in high-income countries. And as you can see, the mean CD4 count at care entry was 336 in 2011, which is below the 350 CD4 count threshold that define late diagnosis. But most worryingly, the mean CD4 count did not significantly increase since 1992. In 20 years, CD4 count at care entry only increased by 30 cells per microliter. And this, despite advances in HIV diagnosis, prevention, and clinical care developed and implemented over this time period. In low and middle income countries, there is a lack of data on individuals newly diagnosed with HIV and those entering care. Usually what is available in this setting is data on individuals initiating ART. However, I found this recent study reporting on CD4 counts at care entry in 4 low-income countries. So on the figure, you can see that overall, CD4 count at care entry increased from 238 in 2006 to 286 in 2011. However, this increase was essentially driven by an increase in CD4 count at care entry for women. For men, the CD4 count at care entry remained low and around 200. So not surprisingly, this data suggests that HIV-infected individuals in low-income countries enter care at a later stage than individuals in high-income countries. A more intuitive epidemiological indicator, but less straightforward to obtain, to evaluate how long it takes for an infected individual to be diagnosed, is the time interval between the actual time interval between HIV infection and diagnosis. So we used surveillance data on newly diagnosed HIV cases and a back calculation model to estimate this time for each transmission group in France. And you can see the result of our study on the figure. So in France, in average, it takes 37 months, more than 3 years, for HIV-infected MSM to be diagnosed. And this time is even longer for heterosexual men, as it takes 53 months, so in average, almost 4.5 years for them to be diagnosed. So this study shows that even in settings where there is universal access to HIV testing and universal health coverage, the average time between infection and diagnosis remain very long. Okay, so we have some way and some data to assess the timeliness of HIV infection, of HIV diagnosis, and how it evolves over time. Now we need to characterize the hidden epidemic. So again, this is not straightforward because, like for new HIV infection, we cannot directly observe undiagnosed infection. But we can use mathematical modeling and surveillance data on newly diagnosed HIV cases to get some information on the hidden epidemic. So here are the results that we obtained for France. So quickly on the result. We found that 29,000 individuals were living with undiagnosed HIV, which represent around 20% of people living with HIV in France. And interestingly, 2/3 of undiagnosed were men. So we found that universal HIV testing could be a cost-effectiveness screening strategy in France. So characterizing the hidden epidemic is essential to guide HIV testing strategy and to assess the impact of this strategy. But very few countries have reported, estimated on the hidden epidemic, especially in low and middle income countries. So besides evaluating the time to HIV diagnosis and characterizing the hidden epidemic, we will need to increase uptake of HIV. This can be done by reducing further HIV-related stigma and discrimination, providing universal access to HIV testing, affordable care and treatment, increasing HIV testing opportunities by implementing new HIV testing and intervention, such as home-based testing, self-home testing, or community-based testing. Also, providing individuals with new HIV prevention methods, such as pre-exposure prophylaxis, is likely to have an impact on HIV testing uptake. For example, in PrEP trial, 10 to 20% of individuals willing to participate to the trial were found to be HIV positive. So for these individuals, I guess they learned that they were infected earlier because they wanted to take pre-exposure prophylaxis. So the last point of my presentation, preventing the acquisition and the transmission of HIV using prevention method. So here are the HIV prevention methods that are currently available. So in the following, I'm going to quickly discuss the effectiveness of some of the HIV prevention methods that are not based on antiretroviral treatment. In the next presentation, Marion Cohen will talk about the ones that are based on antiretroviral treatment. So here are the list of successful examples of behavior change. The first successful example of behavioral change that led to decreased HIV incidence were reported in MSM communities in the US and Europe early in the epidemic. In 1990 also, Uganda was also successful in decreasing HIV prevalence from 18% in 1992 to less than 7% in 2003. And Senegal also succeeded in keeping the country's HIV prevalence below 1%. But reduction in high-risk behavior are very challenging to maintain. Today, HIV epidemics in MSM communities in Europe and US are uncontrolled. In Uganda, there was a significant increase in HIV incidence from 2005 to 2012. And in Senegal, recent data suggests that HIV prevalence is very high among MSM. The effectiveness of condom. Pickerson showed that male condom decreases the per sex act probability of HIV transmission by 19 to 95%. And then there was a Cochrane review comparing risk of HIV transmission in always condom user versus never condom user that found that condom use reduced the rate of HIV incidence by 83%. And recent studies among serodiscondom couples also give insight on the effectiveness of condom use. In the Rakai cohort in Uganda, where few couples reported using condom, the rate of HIV incidence was 9.2 per 100 person year. Though in the partners and the HPTN 052 studies, more than 90% of couples reported 100 condom use. And the rate of HIV incidence was 2.2 and 1.9 per 100 person year, respectively. So if we compare these two liter rates with the one observed in the Rakai study, in the Rakai cohort, we also find that high condom use decreased the rate of HIV incidence by around 80% compared to low condom use. So these data show that condom is highly effective in preventing the sexual transmission of HIV when used consistently and correctly. However, this data also show that the risk of HIV transmission remains and is not negligible. Male circumcision. Ecological and epidemiological evidence has suggested that circumcision may reduce HIV transmission. And voluntary medical male circumcision in adults was tested in 3 randomized clinical trials in sub-Saharan Africa. And their results were remarkably consistent. They found that male circumcision reduced the risk of HIV transmission by almost 60%. And furthermore, post-trial follow-up data showed that the protective effect was sustained over almost 5 years. So there are two main challenges regarding HIV prevention method. The first challenge, like we saw it for condom and behavior change, is adherence to prevention method. All HIV prevention methods, except circumcision, or one day if we have a vaccine, need continual adherence to be effective. As shown on the graph, without perfect use of HIV prevention method, the effectiveness in reducing the risk of HIV transmission will be quite low after 10 years of use. And the second challenge is access to these methods. In low and middle income countries, for example, in 2011, only 50% of individuals had access to HIV testing, 78% to condom use, and 90% to voluntary male circumcision. So to conclude, I will summarize the main point of my talk. So we need to know where will the next 1,000 HIV infections will occur. For that, we need real-time estimate of HIV incidence, so which means that we need to strengthen HIV surveillance. And we also need to know where to implement HIV testing intervention, being able to assess them and possibly reorient them. And for that, we need to know the time from infection to HIV diagnosis, and we need to describe the hidden epidemic. We also need to provide HIV prevention combination and increase adherence to prevention method. And finally, we need to increase uptake of HIV testing by implementing new HIV testing strategy and using new HIV prevention method. One way is providing new HIV prevention method that require testing. So I would like to thank again the organizer of this conference, and as well as the ANRS and SIDAction for funding my research activities. Thank you.
For a few questions, if you have any, les questions peuvent être en français ou en anglais, comme vous le souhaitez. Il y a des micros au milieu, dans les différentes allées. Oui, à gauche.
Yes, morning. My English is very bad, but I have to improve it. And I will try to speak in English. Please, would you confirm you think it's necessary to implement generalized testing in the whole population, first of all, in countries with low rate of prevalence, and especially among women who represent, if I'm not mistaken, 53% of heterosexual infections, in particular among women over 50 old. And if I'm not mistaken another time, they constitute an important part of hidden population, no?
Yeah, but this will depend on what we know about the hidden epidemic. But as I told you, there is no many estimates of the hidden epidemic. As I know today, there were some estimates for US, for France, and also for MSM in UK. So without knowing it, knowing it helps you to know which HIV testing intervention or strategy could be cost effective. So, for example, in France, we saw that 2/3 of the hidden epidemics are men. So, targeting men and offer universal testing to men, for example, in France, would be cost effective. So,
but
that's one way.
MSM.
MSM.
No.
Because
heterosexual is less. The rate.
No. The rate. Sorry.
Than women. No.
I will show you the rate for France only. If you look at the rate are on the right column, right?
Yeah.
So obviously, if we succeed targeting MSM, the rate is almost 300 per 10,000.
Yes,
so if we succeed targeting them, or if we succeed targeting IDUs, all these strategies are cost effective, because it has been estimated for a strategy to be cost effective in France, the rate has to be above 10 per 10,000. So it means at least finding one undiagnosed individual when you test 1,000 persons. So obviously, targeting MSM and targeting IDUs are cost effective. But we can see also here that the prevalence for men is 10 per 10,000. So
it's MSM plus
heterosexual.
Yes, of course.
It's MSM plus heterosexual. And so targeting men, for example, especially in the region of Paris, where HIV prevalence is higher than other regions of France, would be a cost-effective strategy for France. Mm-hmm. So to decide that, we really need some estimate of the hidden epidemic. And so far, most countries don't have estimates.
Mm-hmm. Thank you.
Okay.
Yes, in the middle. In the middle? Yeah.
Please give your name.
Council. I think that, okay. Giovanni Maga from Italy, National Research Council. It's just a very quick question. So in your opinion, would home-based self-testing be effective? Because the impression is the point is not only having the test done, but also having it as a beginning, of a connection with the healthcare provider. So a test without counseling sometimes will not be really accepted, will not be communicated, will maybe not be correctly interpreted. So what's your opinion about implementing self-testing as a general policy for prevention?
We need to know what kind of information, need to be provided with home self-test. And actually, we might do this kind of study in France, soon. But I guess, we have to have, testing solution for everybody. Maybe it's not going to be convenient for everybody, but some people that want to test on a regular basis, maybe they're tired to be cancelled all the time. you know. So maybe for this person, it would be a good tool. And for other people, obviously, I mean, the counseling would be maybe important too.
Thank you.
Okay, thank you. Virginie, maybe a quick question. You highlighted the need for more HIV incidence data. What about also documenting what I will call a community viral load now? Isn't it more important than just simply the incidence of new infections?
Yeah, it's also very important. But what is also difficult with community viral load is then at the end, I mean, you have some information on the quantity of virus that is circulating in the population, and we hope that you know, this might be related then to HIV, the risk of HIV transmission. But this also depends on the, you know, who is mixing with whom. I mean, so yeah, I think it's an important, I mean, indicator, but not as easy as interpret them,
okay,
as we think.
Thank you very much. Okay, so we will move to the second speaker, and it's really a pleasure and an honor for me to invite Mike Cohen to talk. So Mike Cohen is professor at the University of North Carolina, Chapel Hill, USA. He has been really one of the leaders for many years in the field of prevention of sexual transmission. And as you may remember, the magazine Science elected him the Scientist of the Year in 2011 for the breakthrough discovery of the HPTN 052. So Mike, you have the floor.
Thank you for inviting me this morning. And I'm going to continue with Dr. Supervi left off.
Don't have the...
Working now? Yeah. Okay. Let's see if I can get these slides to go down. Okay, so the conflict of interest that I would have are shown on this slide with advisory boards of a couple of companies. But the most important thing is that I have I help direct an NIH network called the HIV Prevention Trials Network. And so as I talk, a lot of what I say is oriented towards the studies we're doing and towards the future. So I don't see that as a conflict, but it's important to realize that it gives a certain light to what I say, because there's a lot of science going on. A lot of what I say will focus on the science supported by the U.S. National Institute of Health. Now, I really want to talk about three different things. The first thing I want to talk about is make sure we all agree about the transmission of HIV, because that's what we're trying to present. The second thing I'll talk about is trying to use antiretrovirals and other agents to prevent HIV acquisition in a person who is HIV negative. And the third thing I'll talk about is the treatment of infected people and the implications of the treatment of infected people to prevent the spread of HIV. So all of us in this field use this formula to understand where we're trying to go. Rho equals beta delta C. So we understand that when R is greater than 1, R naught is greater than 1, that the epidemic will get bigger, and we're trying to make that R naught less than 1. We calculate that number by multiplying three things. Beta, the efficiency of transmission of HIV from one person to another. D, how long does someone remain contagious? And C, how many people does the infected person expose over some period of time? This is how we understand the spread of HIV. Now, it turns out that beta, the efficiency of HIV, this virus is not very efficient. It has difficulty going from one person to another. And it turns out that, so when you look at the literature, at the probability of a sexual transmission event, most of the literature suggests that for heterosexual sex, it takes 1,000 episodes of intercourse for a transmission event to occur. 1,000 episodes of intercourse is a lot of intercourse. And it would be very hard to understand the epidemic if the beta, the efficiency, were as low as it's been estimated. But over the years, we came to the conclusion that that efficiency is not right, because the efficiency is amplified. How does the efficiency become amplified? In two ways. First of all, for the person who's HIV infected, anything that increases the concentration of virus increases the probability of a transmission event. And the ideas are shown on the left hand of the slide, and we'll come back to acute infection in a few minutes. For susceptibility, anything that increases the number, that damages the mucosa or increases the number of cells will increase the transmission event. Now, both gay couples and heterosexual couples commonly have anal intercourse. And the probability of a transmission event when the mucosa involved is the anal mucosa is greatly amplified because there's a constant inflammation, a low level of inflammation in the anus. It's a very thin, friable tissue, and it is easily understandable how transmission is amplified by the act of anal intercourse. Now, the other thing we've learned a lot about our group and others is about the actual moments of transmission. And there's two ways of looking at the moment of transmission. One way is the biological way, and the other is more of the epidemiological way. For the biological way, we know that the person who's HIV infected, who is untreated, has not only a large concentration of HIV in the genital tract, but there are many different viruses available. It's not one virus. The mutation rate is so high in HIV that there are thousands of different viruses. But it turns out that the genital tract is a compartment. So the number of viruses available in the genital tract are smaller than in the blood. The number of variants are smaller than are in the blood. And there's what we call clonal amplification. So one virus will reproduce to a higher level than others. Then, as the virus in the genital tract tries to find its way to the next person, there's some sort of a bottleneck, a blockade. So when the transmission event, if you start out here with all these different viruses, when a person actually acquires HIV, 82% of the time they only get one virus. And if they don't get one virus, they only get 2 or 3 viruses. So the transmission you're trying to prevent is not all these different viruses, you're trying to prevent one virus. And the issue is really, what is so special about the virus that made it across all these barriers? And a tremendous amount of energy in prevention has gone into understanding what makes the one virus that causes transmission so special. The other issue for transmission we need to all agree on is about acute infection. So here's a negative person, and here's the transmission event. And for the first few days after the transmission event, the virus is only in the tissues. It cannot be seen in the blood. Then the one virus that got across starts multiplying. And that virus is going to grow to its highest concentration in that host that it will ever achieve. So it goes from no virus to the highest concentration of virus over a few days. So logically, if the concentration of virus helps to predict the transmission probability, the highest transmission probability must come in the first few days after the virus is acquired in the person with acute infection. And for that reason, we have a big problem. First of all, we see the person with acute infection who does not know they're infected, is not treated, and will generally not be treated. We see those people forming clusters of transmission. So we find one person with acute infection, and as we try and find their partners, we find another person with acute infection and another person with acute infection. The clustering demonstrates to us that a substantial amount of HIV transmission must come from people with acute infection, early acute infection, the first few weeks. Actually, we think it's about 3.9 months. So we think the maximal transmission in this window is about 3.9 months. The question is, for an epidemic, how many new cases come from the acute infection patients, and how many new cases come from the chronic infection patients? There are so many more people with chronic infection than acute infection. Chronic infection must always be more important. But acute infection, we will not be able to constrain the epidemic, to control the epidemic, unless we can deal with acute infection. So a lot of time has gone into acute infection. Now let me ask a question. Can you understand me at this rate of speed? If I speak at this rate? Most Americans cannot understand me. So speaking in France, is this the right speed? Okay, I can talk very, very fast. And my very fast requires oxygen. So I would only slow down to breathe. But for you, I am going to talk unbelievable. This is going to be like my ability to try and control how many words I use. So I apologize for. But as I said, the Americans don't like my speech either. So don't feel special. Okay. So these are all the ways we know how to stop HIV transmission. And Dr. Supervi did a great job at talking about the unexposed person and some of the interventions that we use that are not biological to protect the HIV-negative unexposed person. But I'm going to talk about biological interventions, and Dr. Gerard's going to talk about vaccines. So I'll talk about things other than vaccines. We don't have a vaccine. Of course, that is the most important thing we could do, is to make an HIV vaccine. Because if you think again about the acute infection person, the only way to really protect the entire population from acute infection is to vaccinate the entire population. That's the most important intervention. But in the absence of a vaccine, we can't just do nothing. We must do a lot of things. Now, I would argue that we've spent about 30 years on behavioral and structural interventions for the unexposed person, and there's a lot of frustration. People say, well, did that really work? Was that really a good idea? But we don't know how big the epidemic would be had we not done all that. You see, all that we've done with condoms and circumcision, those have made a contribution, but the contribution is very difficult for us to measure for a variety of reasons. So now we'll talk about biological interventions. Now, the beginning of this discussion about antiviral therapy is this very complicated slide, but I'm going to make it simple. On this slide, there are three tissues, the rectum, the vagina, and the semen. And they're all the drugs we use, all the classes of drugs. And as we tried over many years to develop strategies to stop the transmission of HIV, our main goal was to make sure we could understand which drugs get into the tissues to protect the tissues and which drugs don't get into the tissues. We were always concerned about the pharmacology and the pharmacodynamics of these drugs. So with my colleague, Dr. Kashuba, we worked on this for a very long time and studied virtually all the drugs, as did other groups. Above the line are drugs that concentrate in the tissues of interest. They get higher concentration in the rectum and the vagina than they do in the blood. Below the line are drugs that don't get very well into these tissues. Now, if you're going to try and use antivirals for prevention, you want drugs that concentrate in the tissues at risk. So this was the first step. This took a very long time to understand all this. So then we get to, if we just logically think about this, we get to the HIV-negative person, and we think, okay, can we use drugs that are above the line to protect people who are HIV-negative from getting HIV? And currently, there are two things that we need to discuss. First, there's the combination of tenofovir and FTC as the approved antiretroviral prophylaxis because of clinical trials that demonstrated you could protect humans with this oral pill if given once a day. And then the second thing we need to discuss is the development of new agents. Now, and I'll come to that in a minute. So let's just talk about tenofovir first. In the NIH network that I run, we're doing other studies to try and understand how to improve the use of Truvada. We're doing studies of the pharmacology of Truvada to understand how infrequently could you take it and have it still be effective. We're doing studies of giving dosages less frequently than every day to understand whether that works out. But our most important study is called HIV Prevention Trial Study number 073. This is a study of about 200 African-American, these are Americans now, African-American gay men. And the study is designed to understand whether these men will actually take these pills reliably over some period of time. So the men participate in behavioral counseling just to say, do you want, we'd like you not, they're HIV negative men, and we're trying to help them stay negative. But in addition, at any point in the study, they can take Truvada, the pill, and then we monitor their blood to see are they taking it frequently or infrequently. Because if this pill is ever going to work, people who are at risk, and the highest risk in the United States is among gay black men, about 7% risk in the cities of the United States, 7% per year will acquire HIV. If a gay black man in New York comes in with syphilis, he has a 14% chance of getting HIV in the next 12 months. So we have a very high-risk population, and the benefit of FTC-TDF for this population can only be realized if the people want to take this pill. If they don't want to take the pill, there's no hope. Now, it's important for me to point out that the U.S. Center for Disease Control, the CDC, just last week announced their formal guidelines for this pill. Their formal guidelines are found at this website, so you can see exactly what the U.S. government thinks about this PrEP. But what's important is the US government loves this. The people running the government at the CDC, they really believe that this has a future, and they would like a very large number of the highest risk people to take these pills. And they say the only approved pill is Truvada. They say that some people might take tenofovir alone, but it's not approved. They define the risk groups, which are the same groups as shown in the suitcase that Dr. Supavi showed from the slide of the suitcases. They define the risk groups, and they talk a lot about the importance of taking the pills every day. The only way these pills have been shown to work is if they're taken every day. So these official guidelines are helpful, and many agencies, I don't know about the French agency, they'll probably sign on to these guidelines because they were very well thought out. Now, and either it will turn out over the next 10 years that these pills will be important and people will take them, or it'll turn out that no one takes these pills. And to my knowledge, no one knows what's going to happen. However, even though we don't know what's going to happen, we're trying to develop things better than these pills. What might be better or different than these pills? Well, there's the topical agents, especially for women. There's another oral agent, Maraviroc, and then there's the injectable antivirals. Okay. Now, Dr. Weinberg yesterday said in the opening session he was not very excited about topical agents. I think that's wrong. Among the universe of opportunities, of options, the most important thing going on right now are these rings. So these long-acting rings can be impregnated. They can be put into the woman's vagina and sit on the cervix for 30 days. They can be impregnated with drugs and birth control. So a woman can use a ring and have birth control and an antiretroviral at the same time. And the most important studies that are going on in this field are called IPM027 and MTN020. And these are very large studies of women who volunteered, high-risk women, in Africa, mostly, volunteering to use these rings as reliably as they can to see whether dapivirine, which is the antiviral drug in the rings, will stop the acquisition of HIV. Now, what's important here? These are the timelines. This is 2014. In 2015, we will know if these rings work. If these rings work and prevent HIV for women, the world will change. And this will be probably the most important discovery of the last 5 or 10 years, because a woman could go to a store and buy this ring and protect herself from HIV. It's not going to protect from all the other STDs, which are important, especially for women, because they can cause infertility and pelvic inflammatory disease and lots of other problems. But this will be a really big event in the HIV field. It'll also be a big event in the research field, because any trial we do, like a vaccine trial, if this becomes the standard of care that a woman could have these rings for free, that will make it much more difficult to test any new agent to prove that the new agent works against HIV. Does that make sense? Because the control group will not be a placebo. The control group will be these rings. Now, if these rings don't work, if the rings work, it's fantastic. If the rings don't work, it's a really, really big problem. First of all, we spent $200 million of somebody's tax money. And second of all, it'll be a big problem for the topical agent field. So the next idea are other agents. Well, one other very simple idea is Truvada is the main drug used for therapeutics. What about another pill? So the other pill being studied, at least for safety, only for safety, is the pill Maraviroc, the CCR5 inhibitor. So we're doing a very large study called HBTN069, which tests the safety of Maraviroc in HIV-negative people. Only safety, nothing about efficacy. And then you heard yesterday about 2 injectable agents, TMC-278, which is injectable rilpivirine, and GSK-744, which is a novel integrase inhibitor, very much like dolutegravir. So the injectable agents are a big deal, and there's 2 studies. Now, the injectable agents have to prove safe. You've now put a drug in somebody that's not going to go away for several months, and for the GSK drug, it's not going away for a year. So once you put that drug in, there's no way to get it out. If the drug has any toxicity, that will become a big problem. So we're doing 2 phase 2 trials, not efficacy, only safety. One of the trials is being done in 132 women at 2 sites in the United States and 2 sites in Africa to see if it's tolerated and it's safe. These injections require 2 shots every few months, 4 cc's, big volume. So the subjects taking them have to keep coming back to the clinic and prove they're willing to take the drug. With GSK 744, again, a safety study. 8 sites, 3 in Africa, 1 in Brazil, and 4 in the United States. This study done in men and women, 160 men and women. These studies take 2 years. The studies just start next month, June. They take 2 years. 1 year of injections every few months, at least 4 injections, and 1 year of complete follow-up to prove no one got sick. So the earliest that anyone will learn anything about using these drugs actually for prevention is 2 years from now. So that's the story. There's one other safety trial called ECLAIR. Now, the other issue here, before we leave injectables. So now we're talking about injectable agents that can stop HIV acquisition. But there's a whole other discussion, and I need to make you aware at this meeting of the other discussion. BNABs are broad neutralizing antibodies. It turns out that through very hard work, many groups have worked on this is the structure of HIV envelope, and there are antibodies that can bind to different parts of this structure that can completely or almost completely block the transmission of HIV, and these are called broad neutralizing antibodies. Human beings, 8% of people with HIV eventually make these antibodies, but it takes years and years and years. But through very hard work, several groups have discovered these antibodies, different antibodies. And these different antibodies, like other antibodies, can block the acquisition of HIV. Now, how could these antibodies being used? This is the big idea, and the Gates Foundation is putting a lot of time and money into this. Well, one idea is that they could prevent transmission of HIV. You could give a baby who's breastfeeding an antibody, and the baby could keep breastfeeding and not get HIV because the antibody would stop the acquisition of HIV. Another idea is to prove how you make a vaccine by making a broad neutralizing antibody study. Show that the broad neutralizing antibody works in a passive immunity study. You just give a shot of the antibody, and then if it works, you say, this is what the vaccine must be. And the third big idea is to cure HIV infection. So there's a monkey study in Nature where Dr. Baruch gave the antibodies to monkeys, and some of the monkeys getting the antibodies appeared to be cured with the help of the antibodies. So these are the 3 big ideas. These are the antibodies. One is called VRC01, made by the NIH. Another is called TENI8, made by the NIH. Another is called PG9 and PG121 and PG16, made by the Reagan Institute. Another is 3BNC117, made by Rockefeller. These antibodies can be put in combination. In addition, Dr. David Baltimore and others have another idea. They say these monoclonal antibodies are fantastic. Why don't we put them on a vector called the AAV vector that replicates and put that vector into humans and make the human make the antibody? Now, this is not a new idea. In the hemophilia field, the same AAV vector has been used to make hemophiliacs make factor VIII, small children with hemophilia. So these are all the things going on with broad neutralizing antibodies. And what I need to make clear, because I know it's complicated, is the competition. We have to compete pills, antivirals, and broad neutralizing antibodies. And then we have to make the big decision. So it's very easy to talk about this. We can talk about all these things all day long. But then sometime we're going to have to decide, are we going to do another trial to prove that any of these things work? That's a phase 3 randomized controlled trial for prevention of HIV-negative people, many thousands of HIV-negative people, to try and prevent them over 2 years, roughly, of getting HIV. Well, what agent should we use? Should we use the antiviral pill? Should we use an injectable antiviral? Should we use the broad neutralizing antibodies? Who should we give this to? Should it be sex workers in Africa or gay men in France? Or who should the trial be done in? What do we compare this to? Are we going to compare it to a placebo, or must we compare it to something else? For example, are we going to compare injectable agent to Truvada, which is a much bigger study? And how much will this cost? We are talking, the decision is a decision to spend another $200 million. So this is a big decision. So no one person, even the ANRS cannot make this decision alone. Do you agree? It's a very big decision to launch into these trials. So we're waiting for 2 years from today to decide what's the next big trial. And so 2 years from now, you have a meeting 2 years from now, this meeting, somebody will say, now it's possible we'll do no trials, or it's possible we'll do another giant trial. Okay, so we've talked about how HIV is transmitted, and we've talked about preventing HIV with passive immunity, and with antiretrovirals. But I think that the excitement around treating our way out of the epidemic has been very great. So this is a very simple idea. This is not a new idea. The tuberculosis field figured out a long time ago that if you take somebody with tuberculosis and you leave them alone, other people will get tuberculosis. But if you take someone with tuberculosis and you give them pills every day, you'll render them no longer contagious and they'll go home and you'll stop the spread of tuberculosis. So the simple idea is, will ART reduce HIV and genital secretions? Well, we showed that. But we studied lots of people with taking these pills, and we showed that when you give people these pills, the right pills, the correct pills, you'll stop the replication of HIV. So we knew that there had to be some benefit of treating people. But what we didn't know was how much benefit, the magnitude of benefit. And what we didn't know is how durable was the benefit. Does the benefit last for a month, 6 months, a year, several years? So we decided to do a study in discordant couples. Everyone on the planet who's in a relationship is in one of three groups. They're either both HIV negative, so they're concordant negative, or they're both HIV positive, or they're concordant positive, or there's one positive and one negative, and they're discordant. It turns out that because HIV transmission's inefficient, that that if you look for couples, about half the couples or more will be discordant because HIV is not efficiently transmitted. And if the couples do not get much inflammation in their genital tract, you'll see lots of discordant couples. So we did a study, HPTN 052, which took us about 20 years, 10 years of laboratory work and 10 years of science, of clinical trial. We enrolled 1,763 couples, 278 in the Americas, 954 in Africa, and 531 in Asia. We oversampled Africa because Africa is the epicenter of the epidemic. To do a study like this and not understand the benefit in Africa would be morally wrong. And in the end, the study was not stopped. The study is ongoing. The study is not finished. There's still 1,500 couples enrolled in the study. But the study was made public because the transmission protection was so great. So after only 2 years, it became clear that when you treat someone effectively and you suppress their viremia and they take their pills every day, which these couples did, that you stop transmission almost 100% of the time. It's really 100%, if people are reliable in their pill taking every single day. But people who say, so you have to talk about human behavior for 1 second. First of all, we said to the couples at every visit, don't have sex, don't have sex, don't have sex. Use condoms every time, use condoms every time. But if they use condoms every time, we could never do the study, right? But they said, we're using condoms, we're using condoms. So we were very afraid that the study wouldn't work. But then very quickly we saw 200 pregnant women. So either there's some immaculate event or women weren't telling us the truth about using condoms every time. So then the other issue is taking pills. In this study, we know people were taking their pills because we'd measure their blood level. And then we'd say to people, don't have sex with anybody except your partner. And they'd say, no, we're only having sex with my partner. But then there were 11 people who had sex with somebody else that we could see from the virus that they weren't completely truthful. So even if we can treat a lot of people, there'll still be what we call unlinked transmissions of people who have sex with someone other than their primary partner. Now, the treatment idea, so the treatment of people will stop transmission. I think that's unequivocal. It's not debatable. If people take their pills reliably, they are much less infectious. Maybe not 100%, but very high. But what about the clinical benefit? So it's very clear that if you take pills earlier, and this is a paper we just published last week or 2 weeks ago, that you can stop lots of, if you treat people at very high CD4 count, you still see a benefit. And the most important benefit we saw was against tuberculosis. Now, why at high CD4 count is tuberculosis so common? A guy named Dr. Kaup, Richard Kaup at the NIH, he really has made this clear. When you look at people with HIV at 900 CD4 cells, as the CD4 count falls, different CD4 cells die. It turns out that some CD4 cells take care of CMV, and some CD4 cells take care of pneumocystis, but the first CD4 cells to die are the CD4 cells that control tuberculosis. So what he showed in this very nice paper fits the clinical data. We treat people at very high CD4 count, and we stop the evolution of tuberculosis. The other point that Dr. Lange made yesterday is about CD4 count. If you let the CD4 count fall from 900 cells to 200 cells. When you treat the person, they'll probably get 200 cells. But the new 200 cells they'll get back will take many years to come back, and they won't cross 500. They'll still have only 500 cells. But here, when we treated people in this study at 500 cells, 446 cells, within a few months, they had 700 or 800 cells. So the benefit of early therapy is very great. And I know that, I think in France, you're giving people immediate therapy. So I think this argument is over. Lots of papers about this. We published one in The Lancet last year. But basically, there's tremendous benefit of treating people immediately, and the delay in treatment arguments really don't make sense. But they raise an issue I'm going to have to end with. They raise the issue of logistical and cost challenges. Of course, there's logistical challenges. There's logistical challenges to treating hypertension. There's logistical challenges to treating diabetes. There's logistical challenges to treating every disease. But you shouldn't let the logistical challenges confuse the best medical intervention. So I think very strongly the best medical intervention is just to treat people. Now, when you start treating people and you look at observational studies, there are 8 out of 10 observational studies that show when you treat people, transmission goes away. Then Alison Rogers in England is publishing a very important paper. They did an observational study of gay couples, 700 people roughly. And in these gay couples, they're offering ART. And they reported last year that in the gay couples where the index case took ART and was suppressed, there was no transmission. So this is the first evidence. Our work has always been in heterosexuals. This is evidence that the same benefit is seen when anal intercourse, insertive anal intercourse is the route of transmission. The third issue, though, is a problem. So now we have like a good news and a bad news. First, I'll give the bad news. So even in countries where we give lots of antiviral therapy, like in England, Australia, Amsterdam, and we find a lot of index cases with chronic infection, and we give the treatment, even with lots of treatment, we don't see stop of spread of HIV to gay men. Why is that? There's 2 hypotheses why we're failing. One hypothesis is that the small number of people who don't know they're infected are driving the epidemic, and because they're confident about the future of HIV, they're using condoms less. The other hypothesis is that a small number of people with acute infection who don't know they're infected are spreading the disease. And this is a challenge for developed countries, including France, about how to deal with the gay population and the United States, which is why in the US, PrEP has become potentially so important, because it seems like if you can get HIV-negative gay men to participate in PrEP studies, whether pills or injectable agents, perhaps you can have a bigger effect on the epidemic. Now, the best news, I gave you the bad news, but the really good news is the study that Dr. Longa talked about briefly yesterday. And this is from the ANRS is very involved with the KwaZulu-Natal. That's one of their main sites, so I congratulate them on their support of this wonderful site. So this is green in KwaZulu-Natal in 2005 or so, and they did a study where they enrolled 16,000 HIV-negative people to the study. There's no real hypothesis. This is an observational study of 16,000 HIV-negative people where they knew their home address. And they're spread out all over the province. They're selected to represent populations. It's a demographic study. And then, over the years, antivirals became available. But they weren't buying the antivirals. They were just becoming available randomly. And the orange are communities that got antivirals. And what happens is, the deeper orange, some communities get lots of antivirals, some communities get very little antivirals. And so when the HIV transmission is studied in the 16,000 people, some people get HIV, some people don't get HIV. But if you lived in a community that's an orange community, your chance of getting HIV was drastically reduced. In the orange community, you had at least a 50% reduction in the probability you were going to get HIV. If you lived in a greener community, less ART, your chance was twice as high or greater that you were going to get HIV. And the implication is that the ART itself was stopping the transmission of HIV. Now, this generated tremendous excitement about the possibility of treatment as prevention. But because this is a huge investment, the decision was made to do gigantic studies. So we have 4 gigantic studies. Gigantic study 1 is called POPART, HBTN-071. Gigantic study 2 is CDC Botswana. Gigantic study 3 is ANRS, what's the number? 1249?
249.
12249. ANRS 12249, done at the Africa Center, in the very place where this study was done is now the site of gigantic ANRS study, and then a fourth study, Search Uganda. And all these studies have the same idea. All the studies are going to look at community randomized study, to look at gigantic populations, to understand if you treat the population, does HIV start going away? They're all randomized sort of like this. This is the pop art study. Full pop art is you go door to door, you find everyone infected in the communities you're studying, and you treat everyone immediately, no hesitation. Partial pop art is you do better than the country, but you wait till the CD4 count comes to the old WHO level, but it's going to probably go up a little bit. And the third idea is just don't do anything special. And the hope is that you'll see a 50% reduction in incident HIV representing 2 million people. So if you're avoiding HIV in a population of 2 million people, that's a really big contribution. And the NRS is, you have 3 groups or 2 groups? 2 groups? 2 groups. So they have like what I'd call a full intervention and then some sort of control intervention. So these studies will not be ready for 3 years. So these studies will define how much benefit we can expect from ART, treatment as prevention. Is it really going to work in the places hardest hit by the epidemic? So let me just end. I really appreciate your staying with me for this very long talk. Let me end by pointing out where we are. We are like on a bridge, okay? And things change. It's not going to be the same. We're at this bridging moment. What I hear people talk about is, well, if you treat people, you're going to treat them for 50 years. Well, that's not true. There's no way the treatment of HIV will be the same even 5 years from now. In 1985, everyone died from HIV. In 1987 to 95, we had 1 drug, AZT, and that was a life-saving drug. In 1995, we got triple drug therapy till 2006. In 2006, we went to 1 pill a day. In 2020, we're not going to be treating HIV the same way. And what will happen is it's going to get simpler and better, and so the idea that you're going to treat people the same way for 50 years is just wrong. The bridge will lead us towards interventions that are better than we have now and towards curative therapy. And the cure field, which we're not talking about today, is very robust. You'll talk about it this afternoon. The cure field will lead to changes in treatment. So in summary, to prevent HIV, this is everything we know how to do. We have the HIV uninfected person, we have behavioral interventions, structural interventions, biomedical interventions, and the center right now is ART pre-exposure prophylaxis. For the infected person, we have behavioral interventions, structural interventions, biomedical interventions, and then the center is treatment as prevention. This is what we know how to do today. 10 years from now, this slide will not be the same. I promise you that. So thank you for listening. Thank you.
Thank you so much, Mike. You speak fast, but you bring a lot of useful, terrific information. Question, une question brûlante ou un point de clarification pour Mike Cohen?
Just a question. Thanks a lot for splendid talk. You speak about use of new drugs in prevention. But clearly, we all agree that one major point for prevention is the adherence to treatment. Do you think, and can you comment about that, that taking drugs subcutaneous every month will be better for adherence in non-HIV infected patients?
Yeah, I mean, the success of pre-exposure, right now, we spent millions and hundreds of millions of dollars on pre-exposure prophylaxis, and no one is using it. So the question is it a dead end, or does it have a future? And we don't know. So the belief is that if you were going to have a shot, and the shot was every 3 months, we're hoping every 3 months, 4 times a year, and those same shots might be used therapeutically as well, that the 4 times a year will increase adherence. But it's possible that no one wants the shots, okay? So we don't know. And that's why science requires that we go off
so we have to look.
Dead ends. One point that I forgot to make about community viral load. If you think back to the slide I showed, if I went all the way back, I want to show you something before I forget. Community viral, what's wrong with, we've written a lot of papers where we don't like community viral load. And the reason we don't like community viral load is right here. So suppose you say the community viral load is great. It's 0 copies in France because you're so good at treating everyone. Except what about the 100 people with acute infection each of whom has 100 million copies of HIV. Well, then the community viral load is 10 billion copies, and you're really not doing very well, are you? So community viral load depends on who you've measured this virus in, and you can convince yourself you're doing a great job very easily when you're actually doing a terrible job. And this is one example of that. So,
good point.
Sorry.
Yeah.
Yes,
Good point.
Yes.
That we be able to all drink from this cup of optimism that you present, Myron. It's fantastic, extremely comprehensive. But the flaw that I see in this is the unknowns, the populations that we don't know about, that we refuse to examine, that we won't identify. We have a 22% increase in HIV infection in veterans over the past 10 years who are coming home from the war, both here and the European countries and in Canada who participated in the war. The VA is known, which is the third largest care provider for people with AIDS in the world. The VA is known to be this dysfunctional. There's not one presentation about how we're going to address that. So there are lots of populations, not just veterans. There are many populations that need to be brought into the bigger tent before we start answering the bigger question.
Well, I think no one can disagree. And here's what happens. Everything works at its own time. And it takes activism, like your activism, to make it happen. Remember that we ignored, if you go all the way back to 1980, this disease was only going to be about gay men. And we ignored women for many, many years. And then there was an interest in women. And then we ignored gay men again. And now there's more. So I think the veteran population, other populations, they will have their day. I'm not suggesting it shouldn't be tomorrow. But with the special populations, the main issue is not to forget them, is to keep shining a light on the special populations, because their day will come. And the interventions are the same, whether it's for IDUs or gay populations or whatever. We develop these interventions to deliver them as a different challenge in different populations. So I would suggest you continue to speak out, saying that there are populations that deserve more attention. Enough said. Enough said. Okay, thank you. Thanks. Thank you very much.
Thank you very much. So the next speaker is Professor Marc Girard from Académie nationale de médecine in France. Marc has been fully involved in the vaccine research story of first in Pasteur Institute in Paris, then now he's in charge of also the meeting, the Sangarde in Paris, but now in Annecy. And he has probably a good view of what happens with the long story on the vaccine research, not only in France, but also at the international aspects. Marc.
Thank you very much. It's difficult to talk after Myron. I would like to start my talk, however, by saying that I have no conflict of interest, but by quoting Tony Fauci back in 2009, when he was saying that with any viruses, nature tells us, just follow me, I'll lead you to a vaccine. Whereas with HIV, nature is telling us, if you follow me, you're going to be in trouble. And that's exactly what happened to the field of vaccine development so far. The major difficulty met in the development of an efficacious vaccine has been the tremendous variability of the virus, which is seen, as you know, both at the level of the number of circulating strains, number of clades, number of recombinant circulating forms, etc. And secondly, which is quite obvious through the high mutation rate of the virus, which will make the virus escape neutralizing antibodies or escape cytotoxic T cell responses. And it's no surprise, seeing it from now, of course, that the glycoprotein-based vaccine approaches, such as were tried in VAX 003 and 004, were failures because they elicited neutralizing antibody responses which were not able to cope with the virus mutability. And there also were the two failures of the step and the AGTN 505 trial, which tried to induce T-cell responses using adenovirus 5 as a vector, and they were not able to show protection for different reasons. But at least we now have a few hopes for the future, which I would like to comment on. The first one stems from the results of the RV144 trial, which was this trial done in Thailand a few years ago on 16,400 volunteers. And the comparison of the vaccinees which got the canary pox recombinant prime followed by a GP120 boost showed that there was 31% reduction in the number of infections after 4 years. And this was just at the limit of significance. So people say, well, it's very moderate and so on. At least it's positive. But if you look at what happened early in the trial, at 6 months or 1 year, you get something like 60% protection in the vaccinees. So actually what happened was that there was protection induced, but it lasted only a short while, and then it waned with time. The question was, what are the correlates of protection? There was no neutralizing antibodies, no CTL responses, which could be correlating with protection. There was a clear correlation with V1, V2 targeted antibodies. The V2 loop, remind you, is the one which contains the alpha beta 4/7 receptor on CD4 T cells, which make the cells migrate to the gold. And V2 is actually part of several neutralization epitopes, including one which was very recently described by John Mascola's group in Nature. The second correlation, strong correlation, was observed with ADCC and probably antibodies targeted to the C1 domain of GP120. ADCC, which is antibody-dependent cellular cytotoxicity, has been known for quite a while, but it seems to be much more important than we ever thought of. This occurs through the binding of an antibody to an antigen at the surface of the infected cell, and the antibody, by its FC arm, is going to attract cells which have a receptor for FC, such as the NK cell, natural killer cells, and this will facilitate the killing of the infected cell. There also is another phenomenon called ADCVI, which is not the killing of the cell, but the inhibition of virus production through the burst of cytokines from the cell which has been brought in contact with the infected cell. Actually, it's been a long time that ADCC or ADCVI was observed to play a role in protection. For example, 1998, there was this study of protection of newborn monkeys with passive immunization with a non-neutralizing anti-SIV serum, and there was a correlation with ADCVI. Then there was this study by Hessel, which showed that the broadly neutralizing monoclonal antibody B12 will protect 8 out of 9 monkeys when you passively immunize the animal. But if you take the variant of B12, which has lost the ability to capture NK cells by its FC arm, then it has kept the full neutralizing activity, but then you protect only 50% of the monkeys, which really shows that ADCC plays a major role in protection in that case. This is also true in active immunization. And for example, this was shown by the group at the NIH with using the adeno5 host range mutant as a prime, followed by either SIV envelope or HIV envelope boosts. In the first case, the challenge was with SIV. In the second case, it was with SHIV. But in both instances, it was found that ADCC and ADCVI activity correlates with partial or total protection. And there was no neutralizing antibody in the picture. So that's the first case. The second new approach is that of broadly neutralizing antibodies. We've heard Myron already give a talk on that, so I'll repeat a little bit what he said. these broadly neutralizing antibodies have been identified, which will neutralize 70 to 90% of the HIV strains independent of their clades. They have been used in passive immunization experiments in animal models, such as immunized mice or macaque monkeys, and in both cases they've shown remarkable protection against infection. Their epitopes have been analyzed by X-ray crystallography, and it was found that they target very complex three-dimensional epitopes, which can be either only proteinic, such as the epitopes in the membrane proximal external region of GP41 and PER. There can be only glycans, such as those recognized by 2G12, but in most cases, there are dual, both glycans and protein, and it turns out that the monoclonal antibody, broadly neutralizing antibodies, have a very long CDR3 region, which allows them to penetrate through the glycan shield and reach the proteinic epitopes underneath. So this, for example, is seen in the V1, V2 PG9 antibody, or this is seen in the V3, V4 loop with the PGT series, etc. So all these broadly neutralizing antibodies have been shown to develop over a period of several years, usually 2 to 2.5 years, but only in some 15 to 20% of HIV-infected persons. And they found to be the result of a very long affinity maturation with somatic mutations and, in the B-cell lineage. That probably seems to be a result of a continuous sustained antigenic exposure. Actually, in the last paper by John Mascola's group in Nature, Donia Rose, which I quoted here, this was found also to correlate with superinfection by a second infecting virus. So many of these, as I said, have a long protruding and unique heavy chain complementarity determining region 3. And therefore, it is at this time, very difficult to imagine that we're going to be able to induce broadly neutralizing antibodies by using a classical vaccine. And so there is a long quest for appropriate immunogen which would be able to do that. But at this time, there only are some hopes, but there is no real success. Hence, the development of vector immunoprophylaxis that Maran already alluded to. Vector immunoprophylaxis is the passive immunization of the animal using a gene therapy approach by taking a vector such as the adenovirus-associated virus, AAV, and having it express both the H and the L chains of a broadly neutralizing antibody. And this has been done by Phil Johnson's group in monkeys. This has been done by David Baltimore's group in BLT humanized mice. And in both instances, it's absolutely fantastic because AAV is a long persisting vector which does not integrate. It will continuously express the genes that it has been loaded with. And therefore, there is a continuous expression of broadly neutralizing monoclonal antibody, and the mouse or the monkey are protected against infection, against challenge. So this is a very important possibility. It has not been tested in humans yet, but there is some hope that clinical trials will begin perhaps this year. I quoted Corey and McElroth in a recent paper saying that it is an important strategy to be considered, especially for countries of population with high HIV incidence rates. The third approach I would like to mention is the role of cellular immunity in the control of HIV infection. This is a very old knowledge. Actually, the first demonstration came from Norman Ledvin's group back in 1999 with Schmidt's paper in Science, which shows that if you injected a monoclonal antibody against CD8 to infected macaques, SIV-infected macaques, then you had a huge increase in virus load, which was followed by accelerated disease progression and premature death of the animals. Since then, we have had a lot of studies of human elite controllers who have a viral load which is just at the limit of the detection in the absence of antiviral treatment, and they all show very potent polyfunctional CD8 cytotoxic T cells, mostly against GAG, and they also have a specific haplotype, HLA haplotype, such as B27, B57, etc. And the same has been found in monkeys, polyfunctional CD8 T cells, which stand positive for interleukin-2, TNF, MEP1 beta, interferon gamma, and granzyme, actively suppress SIV replication in rhesus macaques. Therefore, it was quite understandable that there were attempts at using this induction of CTLs to try to prevent, at least, not infection, but at least disease in vaccinated hosts. And as you know, the trials were a failure. However, the group of Louis Spicker has shown a remarkable result using a replicative cytomegalovirus vector, which was in this case the rhesus cytomegalovirus vector, expressing SIV proteins. And this vector, the CMV will replicate for a long, long time, and therefore will continuously express T cell, CD4 and CD8 T cell responses, and especially effector memory T cells responses in rhesus macaques. So what they did was that they infected 24 monkeys, and this slide shows that half of the monkeys in blue were not protected. Nobody knows why. But the other half showed that they could control their infection. These are virus loads. As you can see, there are a few blips here and there for the first 25, 30 weeks and so on. And then this will stop completely. There is complete resolution of viremia. And at necropsy of the animals, there was no virus available, no virus found, showing that the animals had most likely cleared their infection. And of course, this is something which everybody would like to reproduce in humans. The fourth new approach, is that of eliciting mucosal immunity. There have been many attempts at that. One which I would like to quote is that of Bomzel and collaborators, which combine intramuscular and intranasal immunization with a GP41 MPAR peptide, which had been associated with virosomes. And this elicited a strong protection against successive vaginal sheath challenges in female rhesus macaques. The control animals were all infected within 5 successive challenges, whereas after 13 challenges, all the vaccinated animals were still virus-free. The only correlate of protection which was found was secretory IgAs in the vaginal secretion that could block HIV transcytosis. And HIV transcytosis has been described in the slide. As you can see, the HIV-infected cell on the top will secrete the virus, will produce virus at the contact with the monocellular epithelium, and the virus will penetrate into vacuoles, transcytosis vacuoles, which will transport it to the basolateral side, where it will be released and be able to then infect either dendritic cells or directly CD4 T cells, and eventually be transported to lymph nodes, etc. So the blockade of this transcytosis phenomenon has been observed by secretory IgAs in the cervical secretion, vaginal secretion of the monkeys. And a phase 1 trial has been done at this time using GP41 virosomes, and the same type of transcytosis blocking antibodies were observed in the small number of women who were tested. So, in conclusion, there are at least these 4 major approaches which need to be further explored. The result of the RV144 trial should be improved, and it's hoped that a new trial will start soon, using more potent vector than canarypox, more potent adjuvant than aluminum hydroxide, perhaps GP140 rather than GP120, additional booster immunization to make the protection last longer, etc. Then the testing of vector immunoprophylaxis with AAV should be done in human volunteers. The GP41 virosome approach should be developed to elicit mucosal transcytosis blocking antibodies. And then finally, the problem of the rhesus CMV approach, translation to humans is not easy because you're not going to use CMV as a vector, and therefore there is a search for appropriate vector which is still ongoing. I understand that Louis Speaker has some new data on that. Then there are other approaches which I did not have much time to elaborate on. Here at this meeting you can find some information on the TAT-based vaccine, which was developed by Erwan Lauret and who is developed by BioSyntech, and which is supposed to block HIV replication. There is the approach by Patrice Debray's group in Paris to use a GP41 motif which makes the CD40 cell express on their surface a natural killer cell receptor, which will then, of course, kill the cell and will explain a part of the decline in CD4 cell number. And this is in the HIV-infected macaques, the approach has been found to be very interesting, so the vaccine has been developed. But I should add also that there are other approaches, such as the one developed by Jean-Marie Andrieux in Paris, using a lactobacillus. This approach was done on monkeys, and I know that it is being repeated at the time at Emory University, so we should know by the end of the year whether there is a confirmation or not. And then there is all the approaches done at ANRS, mostly with dendritic cell DC-based vaccines. So the conclusion, first, to quote again Tony Fauci, is that the development of a safe and effective HIV vaccine is perhaps the most important and challenging goal which remains in HIV/AIDS research. It's a long-lasting endeavor. We have we lost a lot of battles, but let's say we haven't lost the war. There still are avenues to explore, new candidates to test, and a renewed thinking of how to tackle the problem. I'd like to quote Maud Fontenoy, which is a French solitary navigator who crossed the Atlantic Ocean alone on her little boat, and whose motto is always there, doubt at times, but never quit. Thank you very much.
Thank you very much, Mark. Some question? No? Just a comment from, I fully agree, Mark, that we need for a vaccine, and but as you know, it's a very difficult decision. We have very difficult decision to take about a big trial in prevention for a research agency, but also very difficult decision to take about the program of on vaccine research. And clearly, I said that to be at the head of the NRS is really a great job and a very pleasant job. However, the top to bottom decision about the vaccine program is probably the most difficult decision to take. Because it's not only science, but it's also to decide about good science, but also to research and development area. So it's not only a research agency job, but also a biotech job. So clearly, I fully agree with your comments about that we need vaccine, and it's clearly very difficult to conduct vaccine research.
Well, the best illustration of the point you made is the fact that the RV144 trial, the results were known in September 2009. We are in May 2014, and they hope that they will do the new trials next year. It's a long, long time.
No additional comment? Yeah. Your name, please.
Along with preventative vaccines, we've got at least 5 therapeutic vaccine candidates in development. Penvax, Bacborex, the Therabexis vaccine. Any comments or ideas about how the publicly funded research networks can start stepping up and what type of capitalization that's going to need to start seeing some robust therapeutic vaccine development go forward in the next few years?
I'm sorry, this is not my field, and I was not asked to talk about therapeutic vaccines. That's why I didn't mention them. But I would like to know how you see yourself, because I understand you are active in the field. And is there a good hope for a therapeutic vaccine to be efficacious? Is there?
I think if we don't develop a therapeutic vaccine, the continued proliferation of drug resistance in resource-poor and developed settings is going to overtake the vast majority of the efficacy that we're seeing in heart right now. And if we don't start providing the level of emphasis on therapeutic vaccines that we've seen on antivirals and on preventatives, then we won't have any hope. The vast majority of therapeutic vaccines are coming out of very small companies with very marginal funding, and there aren't very well-defined mechanisms in the research networks, whether it's ARNS or the HVTN or the ACTGs, to move these vaccines forward. We've seen lots of, as you said, lots of defeats, but that doesn't mean that we can give up on therapeutic vaccines any more than we have on preventatives. So combination studies, Penvax and the Therabexis vaccine, and finding out whether Bacborex has anything, or a dozen other candidates could be done. There was one time when we emphasized this.
Well, actually, I would say that, as I showed you, the CMV approach by Louis Picker's group is quite appealing, because if you look at the curves in purple at the bottom, you see that these animals which had been vaccinated and challenged got infected. They had blips of virus here and then they totally controlled the virus load, which means that the reservoir cells were also eliminated through the constant action of the vector-inducing T-cell responses. So that's remarkable.
Perhaps one additional comment about, to my knowledge, I think that we have about between 15 and 20 clinical trials on the therapeutic vaccine at that time, which are ongoing. So clearly there is a research on this area, research in France, but also in the United States and in UK. Probably it's also a good thing to have a vaccine and therapeutic vaccine, not only for therapeutic vaccine, but to see in a short time and in a short delay what happens with a novel tool and a novel vaccine tool. Because if you look at what happens in a phase 2 and a phase 2B therapeutic clinical trial, you know it's easier to have not really a good response, but you have a signal to see if you have a good tool to continue on these topics. Finally, we have to think about not only for therapeutic vaccine, but also what happens with a reservoir and to enhance specific immunity, or not only specific immunity, but also innate immunity and the relationship with the decrease of the reservoir. So clearly, I think that in the next 2 or 3 years, the topics and the general program on therapeutics vaccine will be probably at a high level and better than now. Yeah.
Thank you.
So the next speaker is Professor François Dabiz. As you know, François Dabiz is Professor of Epidemiology in Bordeaux University. He is also at the head of Action Coordonnée 12 from the NRS, the Action Coordonnée, which is in charge of the strategic agenda of the research of the NRS in and with developing countries. And François is very well known for a lot of work on the prevention of mother-to-child transmission, and is now fully involved in different courts in West Africa, and he also the principal investigator of the TASP trial in KwaZulu-Natal in South Africa. François.
Can you hear me? Yes. Thank you, Jean-François, and I'd like to thank the organizers to give me the opportunity to come here. They asked me to basically look into my crystal ball and tell you how and when the epidemic will end. So more seriously, I have no specific conflict of interest to declare on this topic, and I would like to try to divide it into a few pieces from where we are now to the way forward, and trying to make some public health sense of the science that has been already described today or in the previous sessions. So where are we now? In fact, from a sort of general standpoint, we are sort of in a big cycle of since 2000, with many political statements made on the continuation of the epidemic and how we should control it. And there is a first deadline, which is 2015, where the United Nations Millennium Development Goals will be discussed and looked at, and some of them clearly deal with HIV. But more on an epidemiological standpoint, we are still in a growing epidemic, which is not controlled. And these 3 figures tell you exactly this: 35 million people living with the virus, still 2.3 million new infections, and still 1.6 million deaths. So we have not reached what is commonly called now the tipping point, where you would consider globally that the epidemic is controlled. However, this tipping point is already achieved in a few places, and certainly looking at the global figures is now insufficient. So I have highlighted these 3 figures in a different way by looking not only at the picture on the most recent year, but the trends. And the trends are very interesting, because the trends of the new infections here is really down. The trends on death is down and has been down for many years. And unfortunately, the trends for new infections is still up, but certainly not as up as it used to be. So if we focus now on some areas of the world, it looks particularly for the new infections in Africa, the curve is really going down, and going seriously down, and for almost a decade now. So this is really big progress. However, there are other regions of the world, and I've highlighted here Eastern Europe and Central Asia, where the curve is totally different. It's at the best flat, and if not flat, it's going up again. But of course, the scale is not the same. Here you're talking of 100,000 people. Here you're talking of million people. So I will try to do each bit by a conclusion, so to avoid the big conclusion at the end. So where are we now? My conclusion is that we are, first of all, at the end of a cycle. 2015 will be the end of a cycle, meaning that we need to reopen one. The trends that I showed you are quite promising, especially in the most recent year. So you can consider the bottle half full or half empty, but a lot of progress has been made in the past decade. My second point is that in this ending the epidemic, there is one almost no question mark, but here exclamation mark, that meaning we shouldn't see any more clinical disease. And we shouldn't, because we are now treating or targeting to treat many people. In fact, we are targeting to treat 28 million people at CD4 threshold of 500, which is quite a big target. And for this, we have a consensus. In a few countries, Mike mentioned the US, we can also mention France. We have now the target to treat almost everybody, but at the global level, we have already the consensus to treat up to 500 CD4. So we have clearly the goal and the possibility to really reduce substantially and avoid any clinical disease with such a strategy. And let's look at a very sort of, I would call a population laboratory, which is the British Columbia province in Canada. There are reports of a few months ago on the long-term trends are very interesting. First of all, the median CD4 at which people have started treatment now is increasing very substantially, and it's almost reaching the 500 CD4 threshold, so meaning that we are very close to reach people in a province like this at the best time according to the guidelines, although some progress needs to remain to be done. The second is this is a busy slide with many curves, but only look at this one, which is the curve up, which is the cumulative number of people who are treated by ART in this province, and clearly it's increasing dramatically, and it continues to increase. And the third trend in this province is the trend of the AIDS rate, and in dark blue, and the mortality rate in light blue. And of course, we have been accustomed to see this sharp decline at the very beginning of introduction of ART. But the good point here is that you continue to see the decline over the most recent years. So I believe even last month there was a political slogan made but political decision made in British Columbia to close the AIDS ward in the major hospitals of Vancouver, giving a signal that really the disease was almost finished. And if you look at the HPTN 5.2 report that Mike mentioned on the clinical aspects of prevention among serodiscordant COBOL, their interpretation is that early initiation of ART delayed the time to AIDS events and, more importantly, decreased the incidence of most, not all, the clinical outcomes. There will be more trials to come in this area of impact of early ART on clinical disease, and to mention the two most important, the Temprano one and the START trial. These trials target to treat people at relatively high or even very high levels of CD4, and they will look at a bunch of clinical events that will tell us soon if it works for all of them or on most of them. And this is quite likely that if the conclusions are good, this can be translated into public health conclusions, because irrespective of the area of the world where you are, low income, lower middle income, upper middle income, or high income, the median CD4 at which people start a treatment is increasing and is gradually increasing almost everywhere. So these guidelines will be translated into public health practice more and more often, although of course, not perfectly at this stage. So to close this second part of my talk, no more AIDS, yes, it's quite likely that we will see that, or we won't see any more clinical AIDS soon in most settings. At one condition is that ART is initiated early enough. That's a workable target at the global level, and that's a very good political slogan. In fact, Michel Sidibé, the Director General of UNAIDS now, is really putting the Zero AIDS slogan very high on his agenda because that's quite appealing for a lot of from lots of perspectives. Okay, third part of the ending the epidemic, this elimination of mother-to-child transmission of HIV. Again, we have this very simplified and powerful guidelines to do that, treat all the pregnant women and breastfeeding women. And we have this goal in the Millennium Development Goals to eliminate HIV infections among children. Where are we? We are on a very steep decline in the number of new infections. As you can see, most of this decline has been obtained in the past 3 to 4 years, simply because this triple therapy among pregnant and breastfeeding women is now endorsed and implemented in many places. We are still far away from the target, at least in 2012, but the curve is really going exactly in the right direction. The worry for us, as we are speaking in a French country, is that many of the Francophone countries are those who have a low coverage of these kind of services at the moment among the worst case scenario. So it's quite likely that with the interventions that we have, especially the pregnant women taking and breastfeeding women taking triple therapy and reaching a lot of them, we are going to get close to this target of elimination of mother-to-child transmission. Perhaps not in 2015, but rather sooner than later afterwards. And certainly the combination of the use of ART for other population and thus reducing the sexual transmission to women will also help greatly. So the conclusions for this third piece is that this is a workable target. This is also politically important because elimination appeals to many people. We will have a technical problem, which is we need to make sure that we, I would call, certify elimination at population level. Eradication of smallpox, for instance, has been a success because we were able, or our predecessors were able to say and to conclude that there was really absolute eradication in countries. We need to find a way to make sure that we show that mother-to-child transmission is really eliminated and to a certain extent certify this at population level. What about reduction of acquisition of transmission and sexual transmission? I will have the three pieces, and I'll start by medical male circumcision. It's a success story. I say relative because it took too much time to achieve it. But we have 3 randomized trials with comparable efficacy. That's just perfect. This was translated almost immediately into international guidelines. And the promising pilot programs were implemented and showed that, yes, indeed, you could do that not only in a scientific way, but at the global population level. And finally, we learned at the end of last year that not only that was feasible, but that was really reducing incidence at population level, at least in South Africa. So we have really the clear demonstration now at the global level that male circumcision contributes to the reduction in HIV incidence. And this has been translated into action. This shows you here the million of medical male circumcisions that have been performed since the beginning of the guidelines, at least in the key countries where this policy has to be implemented. We are talking of basically 16 countries in the world where this will make sense. However, the coverage is still from average to very low compared to the target. So we are talking of millions of acts, medical acts that have been performed, but we are still very far of the target that has been put on the horizon. And I will just send you to the PLOS series that was published early this month, I guess, on all the successes and also the limits of these various programs rolled out throughout Africa over the past years. So, with regard to medical male circumcision, the job is not done yet. Although we have the science, lots of resources have been invested into that. It's apparently very simple. It's a one-shot intervention, but we are still not covering well the target population. However, there has been a demand that has been created at the global levels in many African countries, and my guess, and the guess of many implementers, is that this demand will continue to grow and the services will continue to be rolled out. Okay, moving to ART and dividing this into ART at the current level and ART with the task approach. ART at the current level, as I said earlier, we are really moving extensively now to target people at levels as high as 500 CD4. In addition to that, serodiscordant couple, pregnant women, children less than 5 years. We are really talking of targeting almost everybody compared to the 33 million people living with the virus. Again, going back to British Columbia and telling you more about the same report. I show you this slide earlier with this nice curve of increasing coverage of ART uptake in the province of British Columbia. Now, if you look at the incidence here, you have a very nice ecological association between increase in coverage and decrease in incidence in this population of British Columbia. And as Mike mentioned earlier, in KwaZulu-Natal, even a much more powerful observation done at the population level in rural KwaZulu-Natal. Again, the same map. The more the red or the more orange the map becomes, the more people treated with ART you have in this community. We are really talking here of using ART with the South African guidelines, which was, less than 200 and less than 350. So we are not talking of even a very extensive use of ART guidelines. And the closer, if you live in a community where there are, let's say, 20% of the people living with HIV who are treated according to these guidelines, or if you are living in a community where there are 30 to 40% of people treated, well, the likelihood of getting infected yourself as a negative decreases substantially. That's, again, almost perfect ecological association. Whether this will be not only effective but also cost effective, in the trial that Mike ran, the HPTN 052, they did a lot of cost effectiveness analysis on this, and the conclusions are extremely favorable for this kind of approach, and so extending the guidelines beyond what they are at the moment. So the next step, or almost final step, is the test and treat, or treatment as prevention. I would suggest something like test and treat them all, the T cube or something like this, because treatment as prevention is probably too restrictive as a slogan. So it's really moving from where we are. It's really to the next here. And again, if we were here really, we wouldn't have a long way to go. But unfortunately, we have not reached completely these points. Is it conceivable to do that, and does that make sense? The modelers have done a lot of work to assist us in our thinking. About 5 or 6 years of modeling exercise have been conducted almost everywhere in the world. And I'll just take the last one because it's probably also closing a cycle of modeling. So the group by Tim Hallett published in the Lancet Global Health at the end of last year. Basically what they published is a completely comprehensive exercise with basically all the modelers in the world, almost all of them working together. 12 models working in 4 different contexts: South Africa, India, Vietnam, Zambia, looking at health benefits, costs, cost effectiveness, effectiveness, comparing 350, less than 500, test and treat key populations in countries like Vietnam. The take-home message, you can read the whole paper if you want, but irrespective of the context, the test and treat approach is an excellent investment on a 20-year horizon according to what the modelers tell us. And that's really closing a cycle where basically all the models have almost said the same thing. Are there risks that could be in relation to that? The famous risk compensation with early ART. Using ART as it is used at the moment in the same population of KwaZulu-Natal, they found absolutely no evidence of increased sexual risk-taking in the general population. They found that the condom use was continued to increase, and the proportion with multiple sexual partners decreased. So absolutely no risk compensation in this context. And in the context of the Temprano trial that I described to you earlier, in which they are using in Côte d'Ivoire ART between 350 and 800 CD4, before even looking at the clinical outcomes, they look at all the social and behavioral consequences. How do people behave? How do they disclose their HIV status? How their unions are constructed and break down, and whether there is discrimination. The first piece of the paper, the first piece of this work was published a few months ago in the Journal of Infectious Diseases. And basically the take-home message from this paper is that the estimated protective effect of early ART in this population using ART early looks like it's very similar to what the HPTN 052 trial concluded in a very strict randomized fashion. Again, as Mike said, there are several trials now looking at early ART, not only for the purpose of clinical outcomes, but now for the purpose of a global set of outcomes, including HIV incidence, NRS 12-249, SURGE, POP-ART. You mentioned two more, Mike, if I remember correctly. Basically, we will have extremely strong evidence with this kind of trials. And yes, I'm partly in charge of this particular trial in South Africa, and I hope that in the coming months, in the following conferences, we will report fully on feasibility and acceptability, because we just closed this phase of feasibility, acceptability a few weeks ago. Unfortunately, I can't tell you more today. So be prepared in 2014, this year, 2015, to have interesting information on feasibility of acceptability of the TASP approach in the field in generalized epidemic situations, and probably in the next 3 years to have effectiveness data on incidence reduction. What about TASP for MSM? Mike mentioned this also, that maybe 2 years ago or even a year ago, it was very unclear whether the test and treat will make sense in terms of results in the MSM population. The partner study presented at CROI was very attractive and made a lot of sense on that, and there will be more to come. I'd like to quote Sue Buchbinder, head of the public health department in San Francisco, at the last Vancouver workshop last month, where basically she said that the TASP approach works, or seems to work in San Francisco, where they have extensive use of ART now, but she had to admit that this may be insufficient on its own to seize the MSM epidemic. So despite this very successful program, but incomplete program in San Francisco, there are now several studies on TASP in MSM throughout the world. And that means also that in the coming years, we will have not only information on the use of TASP for reduction in incidence in generalized epidemics, but also in concentrated epidemics with MSM. So the conclusion of both the ART using the 213 guidelines and the test and treat, or TASP approach, is that, in my view, we are almost there. The real stumbling block is testing, and Virginie presented this quite well earlier this morning, showing some perspectives on that. And that test and treat on its own will not be sufficient, and probably will be integrated, or must be integrated, into a combination prevention approach. So the combination prevention approach should include PrEP. This was reviewed this morning. Here you have the relative efficacy of the HPTN 052 with the treatment in thirodiscordant couples. Here you have the relative efficacy of the male medical circumcision, and here you have the relative efficacy of the various PrEP approaches. This is going to be published in a few weeks in JAMA. This is an update of a slide you have seen, I'm sure, already. And it's obvious that it's a mixed bag at the moment, this PrEP approach. Nevertheless, as Mike mentioned earlier this morning, at least in the US, there is now a very strong movement toward integrating PrEP into the public health policy for reasons that I explained to you, for instance, in San Francisco and in other areas of the US. And so clearly PrEP, although the science has not addressed all the outstanding issues, PrEP now is appearing in the real world. Whether it will be used at the scale that it's supposed to be used, we don't know yet. So the way forward, my conclusion, it's quite likely that we have all the tools of combination prevention to end the epidemic within 20 years. Depends how you define it, obviously. But this implies that we go much more to the communities and we don't wait for people to come to the health system. The counseling and the testing is absolutely critical, central, and insufficiently done at the moment. Treat them all will probably become a slogan soon, although we shouldn't forget the condom. Provide male medical circumcision in the countries where it makes sense, and of course don't forget harm reduction. And if I use a different color and put it in red, this is because combination prevention to end the epidemic could be less than 20 years, because we have this science of prevention that is ongoing. Previous presenters made very good presentations on the perspectives. Who can say when and how these additional approaches on prevention will become available and can be integrated? I'm afraid I cannot, but if they arrive, this will certainly shorten the horizon at which the epidemic will be completely controlled. So, Mike, you are the very nice bridge, straight bridge to cross the horizon. I still believe this is a long and winding road that is not completely accomplished, but my take for closing this session and the end of the epidemic is that we are on the way. Thank you very much.
So, we are late. Two questions, no more? Thanks a lot, François, for the beautiful talk.
Excuse me with my obsessive focus on hidden population. But first, please, would you confirm the end of HIV is not at all something automatic following something like a natural stream? And secondly, do you not think to reach the 3 zeros defined by UNAIDS, the concept of cost efficiency for testing is not pertinent anymore, even for countries with low rates of prevalence? Just an argument. When we will have a vaccine, we shall make it available for everybody, no? And then why not to do the same with the testing? Thank you.
Okay. Thank you. So the three questions are interlinked. Regarding the testing, I mean, clearly testing and enlarging testing is cost effective in most settings. using different strategies. Even in France, for instance, as Virginie said earlier, this has been shown for a few years that we should enlarge substantially the testing approach. This has been translated into a policy, and fortunately the policy has not really been translated into sufficient action. But there is no doubt that the major stumbling block for everything we are talking about today is the testing. Yes, I do agree with that.
I apologize, my English is very broken. I'll try to be clear. I'm afraid this morning, when we consider what happens in Africa, you will see that drug therapy or other means to prevent HIV transmission are not produced in Africa. Providing is depending of non-profit organization or multilateral organization. In the perspective of ending epidemic, don't you think that this situation can be a problem now or in the future in the country which are not able to produce the means, the drugs or other means to prevent HIV transmission? Is this a problem or not for you?
Okay, thank you. And that relates to the previous question. That this is by no means when I show you downward trends for the past 10 years. This is by no means a natural trend, we have the data from the previous decade, which was completely different. So really, this is in relation to the introduction of the various biomedical prevention intervention at the scale where we are doing it, that the trends have reversed in many countries and in many parts of the world. What you are, the point that you are raising is clearly who pays for that, and is this a problem that there is no direct control of the means of prevention by the countries that suffer the most? At the moment, and for the next probably 15 to 20 years, I don't see how we can do differently by an international response. In this international response, every player will have a role, and the scientists in designing the new interventions, the industry in putting them into the proper design, and if they are proven to be efficacious, to produce them and market them, and then the generic industry when the patents are lifted, and we need to find the sustainable mechanisms of financing for that. But I don't believe that the single country can own its own solution. However, over the past years, we have seen that in many countries, first of all, the economic and development situation has changed, and countries that were fully assisted a few years ago can now play themselves an important role in paying the response to the epidemic. And we have seen that has become quite important, and that's a trend that is also going to be in the right direction.
Thank you, François. Just a comment on your last slide. You say we need science in prevention, but I think that we need science to translate results of science to operational research and to the real life. And clearly that's major key and major issue for the next 5 years. It's difficult. It's probably easier in US and in UK than in France, but we have to move on that topic, how to go from results of science to operational research.
Yeah, quite right. I mean, this science of prevention must continue, should have two subheadings, in my view. The first subheading was the one that Mike Cohen mentioned very nicely, is the woman-centered approach of prevention, on which we are far behind what we need. He mentioned the rings and many other approaches. So there is really a need for a woman-centered prevention approach. But the second subheading that I should add is exactly what you say, is the science of the operational science or the operational research to put all the prevention tools that we have already available in place for the maximum number of people. All right.
To all speakers, and thanks a lot also to Alain Lafeuillade and his team pour organiser ce congrès un peu atypique, mais très, très punchy, dans cette très belle ville de Marseille. Donc merci à l'ensemble des organisateurs.